Alright, so the lower respiratory system. We talked about the upper respiratory system and all the problems that can kind of go along with the upper respiratory system. Now we're going to talk about the lower respiratory system. And there's a lot more issues related to the lower respiratory system. And they're a lot more in depth. We plan on spending a little more time on the lower respiratory system. Alright, so we're going to start out with kind of an overview on all of the different acute lower respiratory issues that we'll talk about. And we're going to go into depth with each of these. First, we've got bronchitis. We've got pneumonia, Legionnaire's disease, lung abscess, pulmonary edema, pulmonary embolism, pleurisy, pleural effusion, chest trauma. We've got a hemothorax and a pneumothorax, acute respiratory failure, and acute respiratory distress syndrome. Just a quick rundown. What are the components of the lower respiratory system? Yeah, the lungs first and foremost, right? All right. So we've got our lungs. Okay. All right. How many lungs we got? There you go. Got that one. All right. Now, what are the airways that we have? Okay. Yeah, we got the trachea. And when it goes from the trachea, where does it go to? All right. Okay. And where does it split? What are these two things that split off of here? The bronchi. Okay, the two main stem bronchi. All right. So what's different? And I know this is what we covered day one. Right, is more straight. Got a more direct path to the right lung. Somebody's got it. Somebody's got the video. All right. What happens to the left main stem bronchi? It moves not quite as much of an angle, right? More straight going to which direction? The right side. So why is that important? Okay. Yeah. Everything is more likely to go where? To the right side. You know, things follow a path of least resistance, right? So if our path of least resistance goes to the right side, you're more likely to have what in the right lung? Okay. If we aspirate, where's it going to go? Not always, but you can aspirate either way, but more likely go to the right side. Infection, where's it more likely to go? Go to the right side. All of the nasty stuff that we don't want to have in our lungs, more likely to collect in that right side. Okay. Now, the left side. Can we have pneumonia in the left side? Absolutely. You can have all that in the left side. But the right side, that anatomical distinction makes it more likely, stuff more likely to go to that side. Okay. All right. And how many lobes do we say we've got on the right side? We got 3. You can barely see a little bit of it on the right side from the front. The lateral, you're going to have a lot of that third lower lobe. Okay. From the back, can you even see it? No. You got to make sure that you're auscultating breath sounds from different views. Okay. You can't just do the front. You can't just do the back. You got to do lateral, anterior, and posterior. All right. That's probably what that said anyway. Well, okay. So from here, we've got the two main stem bronchi. Where does it go from? Where do the main stem bronchi split into? Okay. Where are these? All right. These are our bronchioles. Okay. Bronchioles. However you want to pronounce it. Bronchioles. All right. And then where does the air that moves through the bronchioles end up? Alveoli. Okay. All these little sacs that hang out at the bottom. And what happens in the alveoli? Gas exchange. Without the alveoli, I mean, if we didn't have any and you're never going to have a patient, hopefully, if they don't have any alveoli, they're not going to be hanging around very often or very long. But alveoli are necessary because that's where the gas exchange occurs. And what gases are we talking about? All right, oxygen moves into the blood, CO2 moves out. All right, good. So you've at least got that basic review there, okay? It's important to have that review and make sure you can bring back that knowledge so that you can identify these abnormal conditions, okay? All right, so the first one is bronchitis. All right, bronchitis. Now this is not the chronic bronchitis. This is an acute version of bronchitis. It's the same thing. But acute bronchitis can still be caused by the same issues. Well, and we've got chronic exposure. That's not, but it's more of an acute type thing. But inflammation of the bronchi and bronchioles, that's the big part of it, can be caused by exposure to irritants, cigarette smoke, pollutants, chemicals, lots of different things. Anything that could inflame what? The bronchi. Okay? Inflame the mucosa in that bronchi. And what happens with inflammation? Swelling. That's the big problem, right? If we have swelling in any of the airways, what's it doing? It's occluding and making the vessel, okay, or the airway smaller. Okay? That's the big problem. Now, bronchitis is unique only to the airways, not the alveoli. And that's an important distinction, especially when we start talking about the chronic conditions, particularly COPD. All right, now, as a result, okay, we've got all this swelling. We also have a lot of production of mucus. Okay, thick mucus. Thick mucus is produced, and we've already got swollen airways, but now we've got swollen airways that are filled with mucus. So we further shrink the size of the airway. All right. Now, we've got pneumonia. Pneumonia is when we have an excess buildup of fluids in the lungs that results from the inflammatory process, or from an inflammatory process. The inflammation can be triggered by various causes. It could be infectious organisms. It could be inhalation of irritating agents. Now, community-acquired infectious pneumonia, what is that? What's community-acquired? There you go. Something you catch at Walmart, something you catch from walking down the street, something you catch from your kids when they come home. It's community acquired. That means it's outside of the hospital. Anywhere outside of the hospital. All right? So the opposite of that, nosocomial or hospital acquired, you get it at the hospital. They didn't come in with it, and we gave it to them, as a hospital community. Hopefully we didn't give it to them, but we gave them an organism, we gave them the infection. And then what happens? Yeah, that's the big thing. And then you hear about it as a nurse because the administration's mad because they're not getting reimbursed. They're saying, oh, all this is your fault. Y'all caused all this, so we're not going to pay for it. All right? That's just the world we got. All right. Now, some of the manifestations of pneumonia. You might think of any that you might, off the top of your head, think of. Shortness of breath, absolutely. What else? Okay, rales. Yeah, rales and rhonchi. Okay, when do we have rales and rhonchi? When there's stuff, fluid in the airways. Okay, well, not airways, but in the actual lung fields. That's when we'll hear that. All right, stuff's rattling around. All right, when we percuss, and I know y'all don't do a lot of the percussing, do you? Okay, yeah. Well, percuss, if the patient is percussed, all right, they're going to have dullness. Basically, they're going to have density. All right, the lung fields are more dense, so that's why the percussion is going to be there. All right, it's going to be, dullness. All right. Now, another thing though that we can do, okay, when we are inspecting and palpating, when the patient speaks, what might we hear? Okay, well, wheezing, that's another good one. That's another breath sound you might hear. but when I put my palms of my hands on the chest or the back, fremitus, tactile vocal fremitus. Okay, there you go. You say 99. The patient says 99, not you, but the patient says 99, and you'll feel the vibrations. All right. What's another big one that we hadn't mentioned? Fever. Okay, absolutely. Fever. There's even one more. It's a respiratory type manifestation. Cough. I heard a cough. Okay, a cough. With pneumonia, they're trying to cough it up. Okay, hopefully it's productive. Could be productive, non-productive. Most commonly, they're going to have a lot of stuff to spit up, so it's going to be productive. Okay, what type of sputum are we going to have? Okay, could be now. And sometimes it depends on the actual organism. Okay, if it's a bacteria type organism, you may have the kind of the greenish stuff. More likely, commonly, you're going to have the purulent. Okay, purulent drainage. It could be. Well, what's hemoptysis? Blood tinge. You may have blood tinged sputum. Rust colored sputum. Okay. Also, there's one other one. When they breathe in, what might they feel? Tightness, okay, but also pain. Pain on inspiration is another big one. Okay, they breathe in and it hurts. Okay. All right, so dyspnea, increased respirations, hypoxemia, and what's hypoxemia? Low levels of oxygen where? In the blood. Okay. Tissues would be hypoxia. Hypoxemia, that whole emia on the end means you're going to have it in the blood. So reduced oxygen levels in the blood, hypoxemia. Now hypoxia would be a result of hypoxemia. A direct result. Okay. Now you can have hypoxia without having the hypoxemia, but if you have hypoxemia, eventually you're going to have hypoxia. Get all that? All right. Now, there are some patients that are at high risk of pneumonia. Anybody got any ideas of who that might be? Elderly, absolutely. Immunocompromised. Elderly and immunocompromised kind of go together, but if you've got a patient that's not elderly that is immunocompromised, they're also at great risk. Okay, what else? Okay, CF, absolutely. COPD, yeah. Why would they be, both of those, why would they be at high risk? Yeah, the airway clearance issues. Okay, they have trouble bringing in and blowing out. Okay, that air movement. Also, anybody that has painful, maybe they're having pain on inspiration before they have respiratory issues. When might that be the case? Okay, well, asthmatics, absolutely. There you go. That's kind of what I was looking for. Injuries. You got a patient that has had trauma, some type of chest trauma. Do you really, or maybe even a surgery, a planned surgery? I know our scoliosis kids that came in for the spinal fusions. They would have the spinal fusions. They did everything they could just barely breathe in because it hurt to breathe in. They didn't want to breathe at all. It's like you got to breathe some. I know it hurts, but you got to breathe in. So what do we do for those patients to prevent pneumonia? Incentive spirometer. Because what does an incentive spirometer do? It encourages that patient to expand the lungs out and fill up as much as possible so they can breathe out, breathe in and out. All right, but that moves that air in and out, and it helps to prevent, pneumonia, fluid, but also atelectasis. Okay, and atelectasis is what? That collapse of the alveoli, and it won't come back open, right? All right. So, also, what's another patient that's at risk for pneumonia? Immobility, absolutely. Just somebody that won't, can't get up. Okay, post-op patients, 100%. Okay, any others? What about a patient? What about a trach patient? What about this elderly patient? What are they at risk of? Aspiration. Okay, what happens when we aspirate? Stuff goes into the lungs, right? Stuff that's not supposed to be there. So anything that goes into the lungs, you're at risk for pneumonia. Okay? Great risk. That's not 100%. It's pretty dang close. All right. Also, patients that have had what type of medications, or prescribed or non-prescribed, or steroids. Now, steroids may actually reduce. I would think reduce maybe, because they're going to open up the airways and let it come in and out. But there are some medications that diminish what? Vasoconstrictors maybe, but specifically what depresses our respiratory function. Narcotics, pain medicines. So this post-op patient that's already at risk, then we pile on a bunch of morphine, Dilaudid, Demerol, and that depresses the respiratory system, so they're less likely to want to breathe. From a neurological standpoint, it kind of depresses everything, right? So they're at great risk. Okay. Patients that are taking non-prescribed medications, these alcohol, these depressant type, not medications, but depressant type substances. They diminish our respiratory rate. They diminish our respiratory function. They're at great risk. Also, the whole aspiration thing too. There's a lot of alcohol. They aspirate, then they're really in trouble. All right. So, for these patients, what can we do to prevent or reduce this risk? Turn, cough, deep breathe. Okay. What else? Something else I heard. Sinus barometer. Okay. Good. Get them up. Absolutely. Get them up, move them around. Unless we have a contraindication and a doctor's order that says do not get them out of bed, get them up, move them around. Okay. What else? This patient that's at risk for aspiration, what do we need to do? Okay. Turn them on their side. Yeah, but what do we need to do unless there's a contraindication to do what? Elevate that head of the bed, get it up. Leave it up for 30 minutes after they eat. Reduces that risk for aspiration significantly. All right. Next, and this is kind of the same thing, ventilator-associated pneumonia. Now, what type of pneumonia would ventilator-associated pneumonia be? Is it going to be community or nosocomial? All right, this is hospital-acquired pneumonia. They didn't have it when they came in. We put an ET tube down their throat, and next thing you know, they got pneumonia too. So what do we do to prevent that? Well, right here, it's got it. Hand hygiene, okay? Oral hygiene. Don't forget to brush their teeth just because they come to the hospital, okay? If they weren't in the hospital, would they want to have their teeth not brushed? Not likely. I hope not. So, good oral care. And that's another, and even with, the trachs, and I've mentioned it before, these trach patients, we like to forget about the mouth. Well, they're not breathing, they're not breathing anything in through it. Yeah, but that's even worse, because nothing's moving hardly. You don't have that movement in and out that and they're not speaking a lot of times. So they lose that natural cleaning ability we have. And a lot of times if they're on antibiotics, what happens? What do antibiotics do? They kill bacteria. They kill all bacteria, even the good stuff that takes care of the bad stuff. That normal flora. We want to kill off our, all the extra bacteria. So that's gone, and we have fungal growth, thrush, that sort of stuff, and that could lead to even more infection in the lungs. All right, and then again, the head of the bed elevation. Unless we've got a contraindication, they're at risk. Try to keep that head of the bed up as much as we can. Okay. All right, next. You may not have even heard of Legionnaire's disease. If you have, it's probably on the news and you hadn't thought about it a lot, right? Legionnaire's is a severe form of pneumonia that's caused by Legionella bacteria. So it's a specific organism that causes Legionnaire's. It is spread by direct inhalation, and that's a key point. Direct inhalation of the Legionella bacteria, not patient-to-patient breathing. Okay, so it's not respiratory because I'm sitting in the room with a Legionnaire patient and they breathe on me. That's not the cause. It's when they have that Legionnaire bacteria. Usually it ends up in some type of maybe ventilation system. I think there was a Legionella outbreak not too long ago in a nursing home I remember hearing about. Somehow that Legionella bacteria got into that ventilation system, I think it was. Well, everybody that was breathing that air, yeah, they got the Legionella bacteria. Okay. Patients that are at greatest risk are going to be smokers, older adults, and the immunocompromised. That's why the whole nursing home, yeah, it went through it like crazy. Early treatment with antibiotic therapy helps to minimize the severity of the infection. Again, this is a severe form of pneumonia. You're going to have the same manifestations. They're just going to be a little bit more severe. All right. Next, we've got lung abscess. Lung abscess is a localized area of lung destruction due to what? Some type of infectious organism. It builds up and encapsulates in a certain place and then starts to destroy tissue. It's caused by liquefaction necrosis, usually related to pyogenic bacteria, and it's going to result in pleuritic chest pain. The interventions are going to be antibiotics, drainage of the abscess, depending on where it's at, and go in and actually drain it off, and also the frequent mouth care for Candida albicans. So, because frequent mouth care is important to prevent, who's at great risk? Yeah, tobacco users. Who else? Some of these we just talked about, right? Trach patients, ventilator patients. You know? Yeah. I mean, yeah, anybody that has a diminished respiratory system or a depressed respiratory system, immunocompromised big time, okay? And then anybody that's on these antibiotics that are, you know, sometimes they're killing off normal flora, okay? All right. Next, pulmonary edema. Pulmonary edema is a condition caused by excess fluid in the lungs. This fluid collects in the alveoli, making it difficult to breathe. Okay. In most cases, heart problems cause the pulmonary edema, but fluid can accumulate for other reasons, including pneumonia, exposure to certain toxins and medications, trauma to the chest wall, and exercising or living at high elevations. Treatments are going to depend on the source and severity, but usually involves O2 and medications in most cases. So, what's going on in the alveoli? Gas exchange. So we've got a diminished gas exchange. Build up of the fluids. Okay, now this is not... Okay, we've got gas exchange occurring in the alveoli. So what comes through the alveoli for that gas exchange, or at least around the alveoli for that gas exchange to occur? Blood supply, right? Blood comes around, and what happens, and this is, you know, I know it's kind of a disconnect. Sometimes we don't really teach this as much in the CHF stuff, but you got the backup of fluid from the heart, right? Okay. Usually, if we're having congestive heart failure, left side heart failure, the left side is backed up into the heart, or into the lungs, right? So as it backs up, we have this fluid that starts to build. Well, it starts to kind of move out and diffuse out of the bloodstream. Okay, moves out of the capillaries and out into the actual alveoli. That's where the problems occur. So we've moved from the blood supply, fluid's moving into the alveoli. And then if we have fluid in the alveoli, can we fit a lot of air in it? No. So that's the problem. So what are we going to give? And this is commonly a hard issue. So what are we going to give to get rid of this? The diuretics. Okay. When they first come in, they're probably going to try to figure out what the issue is. But most commonly it's going to be a heart issue, so they're going to give the diuretics. Regardless, we've got to get the fluid off of the lungs. Okay, fluid's in the lungs, we can't put as much air in it in those spaces. All right, oxygen. Well, the alveoli that are functioning properly, we want to make sure that they are as full of oxygen as we possibly can. To some degree, we don't want to over oxygenate, but we want to get that concentration up to where we're going to at least oxygenate the patient. Well, okay. Should have showed you this illustration here. This is where it moves out of the capillary and around the alveoli, and eventually it will start to, what's the right word, permeate. It's going to diffuse into the actual alveoli. All right. A is going to be a normal relationship. This is what it should look like. Okay. Look here. Everything's moving around. Everything's good. We're all happy. We're breathing good. Okay. B is increased pulmonary capillary hydrostatic pressure causes fluid to move from the vascular space and into the interstitial space. Okay. So this is kind of a precursor. Right now we don't have it in the alveoli, but it's moved out of the capillary, so we've got a forming problem here. All right, C is when we've got lymphatic flow that increases in an attempt to pull fluid back into the vascular or lymphatic space. So the lymph nodes are trying to come in and fix the problem. Okay. Well, most of the time they probably are not going to be able to do it alone. And D is what's going to be the result. Failure of lymphatic flow and worsening of left heart failure result in further movement of fluid into the interstitial space and into the alveoli. Okay, that's when we've got the breathing problems that result. All right, some of the manifestations. Okay, these are sudden acute pulmonary edema symptoms. Extreme dyspnea that worsens when lying down. All right, this patient, you try to lay them flat and they feel like they are drowning. Why do you think that is? They are. Yeah. Because these alveoli, these air sacs that are supposed to have the gas exchange happen, what happens when we change our position? We got this underlying, there you go, this underlying force that's all around this, gravity, is going to change the position of where the fluid is. Fluid's going to always fall. Gas is always going to rise. Okay? So we've now lost, it's been hanging down here at the bottom, and now it's kind of moving up to the top, spreading out, taking up space, more space in the alveoli, and that prevents more gas exchange from occurring. All right, feeling of suffocation or drowning. This is lying down or standing up, depending on the severity. Wheezes, anxiety, restlessness, or a sense of apprehension. Back to the old example that I gave you the first day. What happens when somebody pulls you underwater and holds you there? You freak out. You fight. You do everything you can to get up to the top so you can breathe, right? Same thing. You start to freak out, anxiety, restlessness, panic, when you feel like you can't breathe. So that's what these patients are feeling, day in and day out. If we don't get some relief to them, they feel like they're constantly drowning. Now, a cough that produces frothy pink sputum. This is a sign that pulmonary edema is worsening. Okay? It's not a good sign. This is a negative sign. If we have a patient that has been diagnosed with pulmonary edema or, has an ongoing problem with pulmonary edema, and suddenly they start having the pink frothy sputum, well, that pulmonary edema has gotten worse. Okay. Chest pain. Chest pain if the pulmonary edema is caused by heart disease. Inspiratory, it's probably going to happen at any point in the cardiac or the breathing cycle. All right. Rapid, irregular heartbeat and palpitations. This could be, well, for one, what's happening? Why is the circulatory system or the heart trying to beat faster? There you go. If we have less efficient alveoli, less efficient gas exchange occurring, the gas exchange that is taking place has to occur more frequently, right? So the things that are working properly, they got to pick up the slack for what's not functioning. So the heart is going to have to beat faster. And what does this typically do related to the cardiac system? Is it going to improve the situation? No. Usually it makes it worse. Kind of back up to the anxiety. If we've got a patient, they've got this going on, so they naturally feel anxious. That's their body's natural reaction to fight and try to get more air, right? Well, what does that do? Does that help the situation? No, that does not help the situation at all either. Because the more anxious you are, what happens? When we go into that fight or flight response, what happens? Everything has to work harder. Okay? So when cells and tissues work harder, what happens? They use more oxygen. So it makes that whole demand. Remember, talked about the fat kid on one side and the skinny kid on one side. The O2 demand needs to equal the O2 supply. Okay? If this is greater and goes down, we need more. Need more and more and more and more and more. If the body can't keep up, what happens? That seesaw starts to tilt. Okay? We got too much over here and too little over here. We got to make up. Got to make up the difference. This is the respiratory insufficiency, and this is usually what these patients are in. The body is not able to keep up, and the body's natural reactions commonly make it worse. Okay? We keep using more and more, but we're not getting any more extra. We're not bringing in any more. We're not normally functioning. A normally functioning person, I don't know if I'm normally functioning or not, but if I get up and run around the building, my normally functioning lungs and respiratory system and cardiac circulatory system are going to do what? They're going to increase their function to increase supply. But if you've got a problem with any of those these systems, and you can't increase supply, all you're doing is increasing demand without increasing that supply. Okay? Does that kind of make sense? Okay. Good. So, where's that recorder? I need to go back to the recorder and play the minutes. All right. So, your body's naturally occurring reaction, okay, is to try to work harder so that you can bring up the supply to even things out, right? To meet that demand. Well, if your body's processes are altered, the body's systems are still working hard and maybe even working harder to compensate, but all they're doing is using more and more and more energy and oxygen, so it makes the problem worse. Does that make sense? If we're normally functioning, yeah, we can kind of keep up until we reach a certain point, and then we have to sit down and take a break to catch up. But this patient, when they're sitting here resting, they're sitting in a chair. They're not doing any extra activity, and maybe they say a sentence. That is enough to tip that scale to where just because they said 5 words together, they can't meet the demand to do that. And it takes them an hour and a half to catch up because they said 5 words. Because they have an alteration in that respiratory system. Next, pulmonary edema, jugular vein distension. Why do we have jugular vein distension? Okay. Yeah. And again, we're not dealing with the heart this time, are we? This isn't cardiac section. But if you don't have the cardiac system working with the pulmonary system, you still got problems, right? You got your heart, okay, divided into four chambers, okay. Heart blood moves here, then it moves to where? The lungs, okay. All right, then it goes through the lungs, and then it comes back to where? Back to the left atrium, goes from there to where? left ventricle, and then where does it go? Aorta, okay? And then out to where? Body, then where does it come? All the way back to where? Back to the heart, the right atrium. Okay? That's the whole circulatory system. It's a nice closed system, right? Well, what happens if we continue to build up and back up from here, the lungs, back to the right ventricle, back to the right atrium, and back to where? From the right atrium, where does it back up to? The body. So where are we going to see these signs? Jugular vein distension. Okay? Now, that's going to occur as a result of what? Now, congestive heart failure, pulmonary edema, is that going to directly cause jugular vein distension? More indirect, right? Because the left-sided heart failure putting pressure on the lungs put pressure where? On the right side, causing the right-sided heart failure to maybe not fail, probably fail because it's insufficient, and that's going to lead back to what? To the body. So then the left side causes the congestive, it's really congestive, that causes the congestion in the lungs, which causes the right side to back up, which causes the right side causes back up through the circulatory system. Does that make sense? Y'all should have already had the CHF stuff, right? Y'all know all this. Y'all should have come up here and covered it. Should have had a volunteer come do this one before. All right, but jugular vein distension. Now that's a bad sign too. Why? Jugular vein distension means that now not only do we have problems here, we've got to back up in the right side and out to the body. So that's a worsening sign, again, of the heart failure and the related symptoms. I didn't lose you on that, did I? I'm getting some blank stares. Yes. Yeah. Oh, yeah. Yeah. This is just that's more of a, that's kind of goes along with the lines of the pink frothy sputum. Things are getting worse. Complications are getting worse. Man. Got some blank stares now. I don't know if it's a good thing or a bad thing. All right. Do I need to expand on that anymore? Okay, good. Maybe that's why the blank stares are there, because you're like, this is stupid. Y'all already learned this. All right. So what's our management, medical management? What's our goal for pulmonary edema? Well, we got to figure out what the cause is. In most cases, it's the heart. We got to fix the heart. Okay. Regardless, we got to pull the fluid off. The medications we'll give, we've got oxygen. Okay. May require endotracheal intubation. So they may have to be intubated, depending on the cause. Okay, or the severity, probably more than anything. Morphine. Why are we giving morphine? Pain and, I heard over here, anxiety. It diminishes what? That oxygen demand. Okay, so it helps with oxygen demand, but it also helps with the pain. So the patient's not quite as annoying to work with sometimes. All right, but it has a physiological reason too. Okay, Lasix. Yeah, we got to pull the fluid off, so this whole system has some pressure taken off of it. Okay, reduce the amount of blood coming back to the heart, and the amount of blood and edema inside and fluid inside the lungs. All right, vasodilators. We got our nitros. Okay, we're going to give those to do what? Open up the vessel. Takes away some of the pressure. All right, dobutamine. Okay, milrinone, digoxin, and Natracor. These are all other medications that are going to help kind of take off that pressure. All right. Now, from a nursing standpoint, these are medications, and again, these are things that have to be prescribed. Right? We're not just going to give these. I don't see any of them on there that we could just give without an order, right? Even the oxygen. We can't just go give oxygen without an order, right? Go. All right. Now, our nursing management, well, Administer oxygen as ordered. Okay, so that's a distinct point there. As ordered, oxygen's got to be ordered. All right, head of the bed elevated. Now that's something we can do, right? As a nurse, you can walk in there, you see the patient struggling to breathe because of all the edema. Well, we sit them up. Okay, legs dangling if possible. What do legs dangling do? Okay, orthostatic hypotension, and it prevents that. But what if, in this scenario, what are we trying to do? It makes this blood coming back, or diminishes it a little bit. Takes some of that pressure off of the right side of the heart. So we let them dangle, and yeah, the circulatory system down here is kind of freaking out because it's harder for it to work and get the blood back. That's kind of what we want at this point, because that's going to take some of the pressure off of the lungs, which are even more important, right? Okay, so let the legs dangle some. Administering and monitoring medications as ordered. Okay, again, medical medication orders, we've got to have the order for, but as ordered, it's another key point. Provide psychological support. What psychological support are we going to have to provide for this patient? They're going to be anxious. They can't breathe. That's it. I mean, they're in that fight or flight response. We've got to calm them down as much as we possibly can. Let them know, hey, we got to, you got to calm down. We are going to take care of you. Sometimes it helps. Sometimes it just makes them matter. Don't tell me do it. Don't tell me you're going to do it. Just do it. So you got to have to fill out the patient a little bit. Hemodynamic monitoring and vital signs. They kind of go together there. We're going to really closely monitor our wedge pressures in here. I know you really haven't talked about that. You'll probably talk about it later. But the pressures, and not only in this system, but also the pressures in the pulmonary system. Okay? What's going from here to the lung? Okay? Carrying deoxygenated blood. What's going from here to the lung? What's the vessel? Pulmonary artery. Pulmonary artery. And why is that a difference? I mean, what's it doing? It's carrying blood where? Away from the heart, so it's going to be an artery. Now, is that oxygenated or deoxygenated blood? Deoxygenated blood. This is the blue blood going away without oxygen, but it's the only artery that's going to carry that deoxygenated blood. All right. So we want to know the pressure here too. What does that help us to identify? If the pressure in the pulmonary artery is up, what is that doing? Where's that putting pressure on? The right side of the heart. Okay? So we want to monitor that. We want to look at that. We want to see how much pressure is the right side having to work against. It's making sense, right? You got to reduce the pressure and the work of that heart. Okay? And we want to monitor it. Monitor its effectiveness. And then vital signs. Obviously, vital signs. What would we expect to see in pulmonary edema, in a pulmonary edema patient related to vital signs? Increased blood pressure, increased heart rate, increased respirations. Absolutely. All of them are going up because everything's having to work harder. Now, if the patient's really, really drowning and can't breathe and all this stuff is not going up, it's not necessarily a good sign either, unless we've given medications or something to depress that. That means the body's not responding to that lack of oxygen. So that's not necessarily a good thing either, unless we have given medications to suppress that. Okay. All right. Pulmonary embolism. What's a pulmonary embolism? Okay, a blood clot that moved, because it didn't originate there, because it's an emboli, or embolus. It moved from a distant location, usually the legs. Okay, deep vein thrombosis. They'll break off and they'll move to the lungs. Now, what's the problem with that? Well, we're going here. We got these a nice blood supply going through the lungs, capillaries. Well, if we've got a blockage that prevents that blood flow from breaking off into the capillaries, what happens? Well, we can't move blood into those capillaries for oxygenation, and around alveoli. All right, so the thrombi most often arise from the deep veins in the lungs, the right side of the heart or pelvic area, and travel to pulmonary circulation. That's what we're talking about. The blood supply, blood flow through the lungs. That's where it's moved to. It can also be fat, air, or amniotic fluid. The key is it's in a medical emergency. I'm not a maternity. Well, it's okay if you think about it. All right, where's the amniotic fluid originally? Well, it's before they're born. I'd have to look that up. I'm not an OB nurse. You're gonna have to ask Ms. Lawless about that one. No, it's not gonna be addressed on this one. You may have it on another one. But yeah, the risk factors. I guess if you're neonatal, I don't know. Immobility. Okay, if patient is immobile, any patient that is at risk for what? Clots. Anybody that's at risk for clots. If they're not getting up, moving around, they're at risk for clots. Patients on bed rest, history of previous DVT, pre-op or post-op. Why would pre-op be a possibility? We're doing what? Yeah, sometimes, yeah, exactly. We'll reduce the blood thinners. Okay, we may say, hold off on your blood thinners. Yeah, I wasn't even thinking about that one, but that's absolutely an answer. What else do we commonly do pre-op? Do we have them up running around, jumping and playing, and usually they're kind of, maybe they may even be on bed rest. But yeah, yours is probably a better answer than I had. So blood thinners. If we take away the blood thinners even for a short period of time, they're more likely to develop clots. All right, post-op. Why is post-op going to be an issue? They're immobile. Okay? Commonly, they're immobile, or it hurts to move, or they just really don't want to get up because, man, every time I get up, I feel that pain in my side or whatever. Yeah, post-op. Trauma. Obviously, I mean, anytime we've had the bleeding cascade begin, well, what's happening? What's happening with the bleeding cascade? Yeah. We have clotting factors that cause a clot. What else do we have? Those intrinsic factors that do what else? They're constantly breaking it down, right? Constantly breaking down that clot. Now, usually they break it down good enough that it's not going to circulate large clots out in different places, but it's always an issue. You got to consider that. But the site of the clot, the site of the injury is clotting, so we're more likely to have those clots thrown. Let's see, what else we got? Pregnancy, obesity, and then birth control pills. You've got the little label on the birth control pills that say, at risk of clotting. There's a reason they have that on there. All right, manifestations of the pulmonary embolism. And these are big. You need to know these because most of the patients you take care of in the hospital setting are at risk for this. So you need to be able to recognize this. Pulmonary embolism, dyspnea appears suddenly and always gets worse with exertion. So they start to work. Well, we've got a clot here. What's happening? We start to move. Activity requires what? More oxygen. Or I guess we'll miss that. More oxygen. It demands more oxygen. Okay? So it's going to get worse. We are depriving ourselves even more of oxygen because the circulation is not getting to where it needs to go. The gas exchange process is not occurring. Chest pain may become worse when you breathe deeply, known as pleurisy. Cough, eat, bend, or stoop. The pain will get worse with exertion, but won't go away with rest. Cough, pulmonary embolism, you may have a bloody or blood-streaked sputum, so hemoptysis. Other signs and symptoms that occur with pulmonary embolism can include leg pain or swelling, or both, usually in the, of one or both, usually in the calf. Now, is that always a sign of embolism? No. That's more of a sign of what? Deep vein thrombosis. But what does that tell us? Okay, if you've got a patient with deep vein thrombosis and suddenly they start experiencing these other signs, the chest pain, difficulty breathing, the dyspnea, all that good stuff, then hey, we really need to investigate a little further, because that may be our issue. Clammy or discolored skin. Basically just means, hey, we are lacking oxygen somewhere. Reduced hypoxia, diminished tissue oxygenation. Excessive sweating, rapid or irregular heartbeat, lightheadedness or dizziness. All right, the excessive sweating and the rapid or irregular heartbeat, what is that a sign of? Anxiety, absolutely. And probably they're going into the what reaction? Fight or flight response. The sympathetic nervous system has been activated. Okay, and then the lightheadedness or dizziness, what does that mean maybe going on? Lack of oxygen to the brain. Anytime, it's probably going to come with confusion, change in mental status, all that good stuff. It could. Because, now, we're talking specifically with the pulmonary issues, but the pulmonary issues, what does the pulmonary system do? It supplies oxygen to the brain. So it could cause, now, usually it's not a direct stroke, what they consider a stroke, but if you've got clots moving to the lungs, you probably also got clots moving where? To the brain, which would be more likely of actual stroke. Wow. 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 It's possible. It's more likely if they're calling it a stroke. More likely it's a actual clot that moves to the brain. That's what they're talking about with a stroke. Yeah. Now you can have hypoxia, which is diminished oxygenation from really more of another source. So the pulmonary embolism could cause hypoxia, but a different clot probably formed and moved to the brain. All right, let's see. How do we prevent pulmonary embolism? Well, get them up, move them around. Active leg exercises, early ambulation. The stockings, okay, the TED hose, pneumatic elastic compression stockings. Avoid sitting with your legs crossed, especially those patients that are at risk. They don't need to cross their legs. Teach signs and symptoms of the deep vein thrombosis and pulmonary embolism. Just basic education. Also, low-dose anticoagulants for those undergoing surgery. That's why, most facilities, if in an adult setting, they're going to get them on something. Ovinox, heparin. They get something when they come into the hospital if they're at all at risk. A lot of physicians just have a standing order. They're going to get every one of their patients that come in for more than a day or two, they're going to have something that they give them. All right, medical management. In an emergent case of pulmonary embolism, it's the CPR. Okay, stabilize the cardiopulmonary system as much as possible. Provide oxygen. Evaluate ABG levels. Start an IV. Lung perfusion scan or CT scan. This helps us to actually look at where the blockage is occurring. and then continuous cardiac monitoring, vital signs, hemodynamic monitoring, and you also want to treat hypotension using dobutamine or the dopamine. All right. Also, IV morphine. Again, same reason. Why are we giving the IV morphine? Reduce the anxiety and reduce the demand. Okay, so that the oxygen that we are able to, we are able to diffuse, we are able to have that gas exchange occur wherever it is occurring, is more effective. Okay, it can get to more places because we're not using it all up on things that, the fight or flight response. All right, again, the compression stockings, which I don't know why we got that twice, but compression stockings, anticoagulants, we've talked about. The heparin bolus drip, so it may be an actual IV infusion. Then we've got the low molecular weight heparin, and then the Lovenox. They've also got Coumadin, the blood thinners that they'll give. Now, the thrombolytic therapy. This is the TPA, urokinase, streptokinase, atelectase, retilectase. These things actually go in and bust up the clots. Okay, these are not blood thinners; these are clot busters. Now, after we give TPA, after we give these clot busters, what's going to be in circulation now? Clots, lots of busted clots. Okay, so what do you think we need to do, or expect the physician to do, for a patient that's on these thrombolytic therapies? They're going to be on a blood thinner as well. So don't just say, okay, well, hey, we've got thrombolytic therapy going. Why are you ordering anticoagulant? Well, they've got to be done together because we can actually cause more clots and more blockages with the thrombolytic therapy if we don't do it in conjunction with the anticoagulant. So you'll see them. They'll have aspirin ordered, or they'll have heparin injections, or the Coumadin, things like that. They'll do that in conjunction. And then surgical management, if the pulmonary edema or pulmonary embolism, if it's severe, they can actually go in and do surgery. Usually, they can remove it, but most commonly the surgery is going to be to prevent the further complications of the emboli. All right, so they'll do an actual filter, this umbrella filter, greenfield filter. Commonly, what they'll do is they'll take a filter and they'll put it like right in here or somewhere before it gets into the cardiac and pulmonary systems, and it filters out all these large clots that would cause the blockages. Okay. And then hopefully we've got some kind of blood thinner that would help to break it up from there so that it can pass through that filter. Now, one of the number one nursing management things is if you've got a patient that's at risk, always suspect it could be a pulmonary embolism. Don't blow off some of these symptoms and manifestations we've talked about. It's real common. You really need to be aware. Most of the patients you take care of in the hospital setting are at increased risk of the pulmonary embolism. All right, so if they suddenly start having dyspnea, shortness of breath, don't blow it off. Make sure that you're being proactive with that. And then prevent formation of thrombus. This is a major nursing responsibility. When we see a patient that comes in, kind of look at the doctor and say, hey, can we go ahead and put up, do the compression devices? Can we put on some TED hose? And usually you can put on some TED hose and then, make sure you got your order for it. But, put them on. Make sure that you are proactive for your patient because this is a big nursing issue. All right? Leg exercises, early ambulation. Encourage the ambulation. If the physician doesn't say to keep them in bed, you can get them up and move them around. Okay? Do it early. When they get back from surgery and they're fussing, they're complaining because they hurt, encourage them. Hey, this is going to get you better quicker, get you out the door quicker, and usually that's a decent, motivator. If they get to go home, that's usually a good thing for them. No sitting or lying for long periods of time. Encourage the patients if they're going on a long trip. What do they need to do? Stop every hour, 30 minutes, hour and a half, however often they can. Stop, get out and walk around a little while. You know, that's why some of our grandparents, it takes them 5 hours to get to a place that shouldn't take them more than an hour and a half. They got to stop at every rest station along the way. Get up and walk around. That's good, though. Okay. Legs should not be in a dependent position. Okay. So over here, we were talking about pulmonary edema. Yeah, we want to dangle the legs. We don't want to have them dangling forever, right? Because then they're at risk of doing what? Developing clots, and then when they start moving them around, they could actually throw those clots. So if they're in a pulmonary edema type situation where they need to just relieve, get some relief from the pulmonary edema, you can dangle. But then, make sure you remember the whole pulmonary embolism risk too. All right. Also monitor IV sites. Okay. Why would that be an issue? Clotting, absolutely. What else? Infiltration. Yeah, I mean, all those things. We're talking about. We are, and what's another thing that we could actually put into the IV that could cause problems? Well, heparin. Yeah, you definitely want to put heparin in, but air. We don't want to provide that air emboli, right? Now it takes a pretty good bit of air, but as far as you're concerned, we don't want to put any air into that IV site. All right. Let's see what we got here. Some other things we need to do: monitor anticoagulant for thrombolytic therapy during the infusion. The patient needs to be on bed rest. Now this is the anticoagulant thrombolytic therapy. Okay, bed rest, vital signs, oxygen sats, limit invasive procedures, monitor the PT and PTT, and then also monitor for bleeding. Particularly if you've got a patient that's had some type of trauma, some type of traumatic incident, some type of large wound or something like that. These sites can suddenly start to bleed, and they can bleed in a hurry. You got to be aware of your dressings, your incisions, all that good stuff. Provide pain management and anxiety management. Kind of go hand in hand there. Calm them down as much as you can. Monitor for complications, including cardiogenic shock, right ventricular failure, and then also educate the patient on these complications and the manifestations. What do they need to look for after they get out, when they go home? All that. Okay, so right ventricular failure. So here, if we have right ventricular failure, what are we going to see? Yeah, the right side of heart failure leads to systemic manifestations. Is that? Well, okay. So right ventricular failure, if it's failed and we push blood out to where? It's harder to get back in. We've got systemic systemic edema. We are more likely to have what? Clot formation. And a clot formation makes us more likely to have what? If the clots move. I think that's what I get out of that. You're looking at this is a risk that could cause. So we would want to educate the patients on identifying these factors, these manifestations. So they're aware that hey, if we gain what? If we gain 2 pounds overnight, sign of, hey, we may have some 2 kilos, pretty good sign. You've got some really significant worsening of that heart failure. Okay. All right. Take a quick break. To come back and start back up at 11 o'clock. I'm going to get Mr. Welsh too and let him know. I think he's going to come back and talk to you a little bit about some of the test questions